what I'm going to do is I'll just be talking about basics of principles of positive pressure ventilation. I'll talk about a little bit of nomenclature, what are the modes and what are the initial settings. And if time permits, then probably we'll touch base upon the various scalars, or at least what are the graphics which are commonly seen and what is their interpretation in mechanical ventilation. This is going to be a very basic lecture for, I mean, there's nothing new into this thing. At the most, it will be a revision. And for postgraduates who are attending, this might be a good lecture for a rapid revision of mechanical ventilation. So when we talk about mechanical ventilation, there are indications which we need to talk about. And the indications are pretty simple. The patient is not breathing, that's an indication for mechanical ventilation. The patient is breathing but is not enough, so that becomes a second indication. He's breathing enough but then is not meeting the goals, that is hypoxia and hypercapnia. So in short, basically if it's an insufficient oxygenation or insufficient alveolar ventilation, the patient needs to be on positive pressure ventilation, be it in an invasive way or be it in a non-invasive way. So what are the benefits of mechanical ventilation? It improves the gas exchange by improving the ventilation perfusion matching, and it decreases the work of breathing. Depending upon your ventilator settings, how much of ventilator support you are giving, it can be either a partial or a full decrease in the work of breathing. So if you look, this is a very nice slide. So ideally what we say is, we all understand that whenever we talk about lung physiology, we say that ventilation and perfusion should ideally be one. That is, whatever amount of ventilation is there, the corresponding perfusion should be there, so that the gas diffuse, and ideally it should be one. But we all know that in theory it doesn't exist, and there are various zones on the lung. And in the pathological spaces, these lungs become more and more problematic. So what we are dealing in mechanical ventilation is about the shunt. That is, you have a perfusion which is there, but with the alveoli is having some problem, or the interstitium is having some problem, and the mechanical ventilation will be acting to keep these alveoli open and to create a decrease the shunt, and thereby improving the VQ match. So what we can see is, there is some similarity between lung and balloon. To make it very simple, what mechanical ventilation does is, there is a pressure generated by ventilators. It's very clear. Now this pressure, it creates a flow of gas across the airway. When I say airway, we'll see what exactly it means. And this flow, when it reaches the lung, it expands the lung, and this is what we call as the volume. So basically, if you can see, there's a pressure generated by the boy. Now that is creating a flow of air from his thoracic cavity through his upper airway and into the balloon, and ultimately there is a change in the volume of balloon. The balloon is expanding. So this is pretty much similar to what we talk about lung and balloon. So in real life, what happens is, the pressure can be generated by a person. Most commonly, we know anesthetists, they use this thing, because isn't it, we do with the hand ventilation, or by bag or by ventilator. This pressure, it creates a flow of gases across the airway. Now when we talk about the airway, it means outside the patient's body and inside the patient's body. So it will be ventilator circuit, endotracheal tubes, and of course the patent airways, all the way down to alveoli. So this pressure is creating a flow of gas, and this is causing the change in the lung volume from baseline, and what we call as the tidal volume. So these three parameters, that is pressure, flow and volume, are going to be there in all the ventilators, and majority of the ventilator scheme will be occupied by the graphs which are related to pressure, flow and volume. So this is something we all need to be very clear about. Now let's talk a little bit about lung mechanics. So when we say lung mechanics, we understand that the respiratory system is made up of mechanical system of lung exchange. Now if you can look at the diagram here, so if you can look, there will be an endotracheal tube, there will be an airway, there will be a lungs, and this lung will be in the chest wall, in which there will be pleural cavity also. So if you look at three major pressures, it will be airway related pressure, it will be pleural pressures, and it will be alveolar pressure, and the resistance and everything will be offered by endotracheal tube, airways and chest wall. So when we talk about resistive elements and elastic elements, I'll go into talk more in detail about this thing. Resistive elements can be because of endotracheal tube, the ventilator circuits, and of course the patient's airway. Airway in the sense, it will almost be up to trachea and the bronchitis. And when we talk about the elastic elements which the respiratory system need to come. That is basically the lung and the chest wall. See, the natural tendency of the lung and chest wall is to go back into the collapsing zone. So if you have to expand the lung, if the ventilator has to expand this lung, these elastic elements as well as the resistive elements, I mean, we need to overcome them. Then only we'll be able to drive the pressure and drive the flow across the various system and create a change in volume, that is the tidal volume. Now, what do you mean by resistance? Resistance is nothing but definition of airway resistance is basically change in the transpulmonary pressure needed to produce a unit flow of gas through the airways of the lung. For example, you see this is a normal airway. This is an asthmatic airway, and this is an asthmatic airway during an attack. Now, imagine we have to create the same flow in the three diagrams which has been shown here. So, but naturally, the normal airway will create the least amount of resistance, whereas an asthmatic airway attack during an acute episode will have the maximum amount of resistance. Same stands true with your endotracheal tube. You have a patent endotracheal tube, no problem. But imagine if you are in an ICU 3-4 days down the line, there is a secretion which is partially blocking the tube, the resistance force increases. Now, this becomes very important to understand that the resistive elements can be because of natural and artificial airways. And artificial, I mean, not only endotracheal tube, your ventilator circuit might be problematic. Very commonly, HME filters in which we use in the ICU, over a period of time, we say that they should be changed every 24 hours. But for some reason, if they are not changed, or if they got blocked with the secretion, they will act as the biggest resistance to endotracheal tube. Now, this air resistance will vary with airflow, the diameter, or the obstruction. Very clear as we explained. So, if you look into the mathematical formula, the resistance will be nothing but as the change in pressure divided by change in flow, isn't it? It's very straightforward. So, if I want to talk about the resistive pressure which will be needed to overcome this thing, it will be change in the flow multiplied by resistance. So, that becomes very simple. For example, if the resistance is more, then automatically the pressure will become more because this is a multiplication factor, isn't it? If I am increasing the flow for the patient, automatically the resisting pressure becomes increased. So this is very clear, I suppose. Now let's go to compliance. So when we talk about compliance, elastance, distinction, it is pretty much the same thing here and there. So compliance is basically change in the volume that occurs per unit in the change in the pressure of the system. So basically, if you look, this is a healthy lung in between, then there's a pneumonia lung, and then there's a emphysema lung. Suppose if I want to give theoretically 500 ml of tidal volume to a normal lung, so probably say I might require 10 centimeters of water as a pressure. But if it is a pneumonia lung, ARDS lung, or a pulmonary edema lung, for same 500 ml, I'll probably need more pressure to deliver. I might need 20 centimeters of water. I might need 30 centimeters of water. That means the compliance is less for this thing. So basically, compliance is nothing. How can you derive the compliance? It is basically change in the volume, say tidal volume 500 ml divided by the pressure which is required to do this thing. For healthy lung, 500 divided by 10 as we calculated, so it will become 50 ml per centimeter of water. But the same thing for pneumonia, it will become say 500 ml and I am requiring more pressure, that is 20. So it will become 25 ml per, that is the compliance has decreased. It's very simple, isn't it? We know, suppose there are 4 postgraduates. Some of the postgraduates, they will listen very early. Some of them you will have to push to do work there. So what we can say is a particular ABC postgraduate is very compliant. He does all the things very easily. A particular postgraduate, he takes his all the time. You'll have to push him and you might say that his compliance is less. Just an example. So when we talk about compliance or elastance, we need to talk about lungs as well as chest wall. Here we gave an example of pneumonia, but imagine a patient of burns, isn't it? He's getting a significant amount of fluid and he became fluid overload, and now you have a chest wall edema. That also adds to the compliance. Okay, so it varies with volume and stiffness, and as we discussed, compliance is nothing but change in volume divided by change in pressure. So if I want to calculate the distensive pressure or the compliance pressure, it will be basically change the tidal volume divided by compliance. Now, why these equations are important, we'll just come to know. Everybody talks about equation of motion whenever they talk about mechanical ventilation, and it is expected even in postgraduates viva that if your viva is really going good, people might ask you what is equation of motion in terms of mechanical ventilation. It's pretty straightforward. What they say is driving pressure, that is a pressure required to drive a gas from ventilator to the patient's lung, is something which is the combination or the addition of driving pressure required to overcome the resistance and driving pressure required to overcome the distension, that is the elastance component. So when we talk about driving pressure of resistance, we all just saw that it is flow multiplied by resistance. And when we talk about the distension pressure, we all know it is tidal volume divided by compliance. So basically, the driving pressure required will be flow multiplied by resistance plus tidal volume divided by compliance. This is very straightforward equation. It looks complicated, but it is straightforward. Suppose if there is an increase in the resistance of this patient, automatically my driving pressure will go up. If there is increase in the flow component, my driving pressure has to grow up. If there is increase in the tidal volume, my driving pressure will go up. Compliance is in the denominator. So if the compliance decreases, my driving pressure goes up. If the compliance increases, my driving pressure comes down. Now, what is driving pressure? Driving pressure is basically the pressure developed by the muscles, that is our own pressure plus ventilator pressure. And this is basically the same thing. For example, if I have completely paralyzed the patient like in operation theater, my muscle pressure becomes zero and all the driving pressure needs to come from ventilator pressure. Is it clear? Now, when I'm weaning a patient, what I'll do is slowly my muscles will start taking over, and there will be a time when my ventilator pressure I will be almost like deciding that my patient is ready to be weaned, and everything, all the work will be done by muscles. So this is something we need to understand. This is very straightforward equation. So now we come to nomenclature and modes of ventilation. We all know that this is pretty problematic. You see, every company they will do different nomenclature and everything. This is a very nice article. If you find time, you people can read it. It's a taxonomy for mechanical ventilation, and there are 10 fundamental maxims. But basic important thing to understand is the ventilator classification system has three components. One is it simply describes the breathing pattern and control variable within the breath, and this is something which is we commonly use bedside. We go and we see a particular patient and we say this is either a volume control or a pressure control or a volume assist or a pressure assist or pressure support. And the next is description of control type used within and between the breaths. Like even within the breath there will be some variation. So there will be distinguishing between similar modes and brand names. So this becomes level 2 sort of classification. And of course, when you want to do a more research and everything, this is more for industry purposes. They want to do a detailed description of adjunctive operational algorithm as to how the feedback is being connected or whatnot. Then you talk about level 3 of classification. In day-to-day life, what we are interested is in bedside. And when you are becoming more of an advanced, probably will be more interested in level 2 classification. For today's purpose, we'll be restricting ourselves to the first classification system, that is description of breathing pattern and control variables within the breaths. Okay. Of course, there are so many things, so it doesn't matter a great deal of difference, but it is very important. We sometimes might ask ourselves a question that why those companies they come up with so much of difference in the nomenclature and everything. I would not say that it's completely because of need of patent act or something. Of course, there are technologies and there is always fine tuning, but at the same time, the patent act makes a huge amount of difference. If you can see, it's a huge market for mechanical ventilation, and the patent act is something which becomes a huge controversy. Suppose if I have devised a new algorithm, my ventilator will correct the feedback from this way and it will give it the breath in this way. The other company will have to come around some way to give the same type of ventilator, but with little bit of modifications here and there. But for us as clinician, whatever ventilator mode we are choosing, we need to be thorough and very good with understanding what are the basic troubleshooting associated with that mode. Now let's go to nomenclature. We all talked about three important parameters, that is pressure, flow and volume. When we talk about pressure, we all know that it's measured in centimeters of water, flow is measured in liters per minute, and volume is measured in ml, or that is liters. Okay. So we have seen the diagram. I'm just emphasizing again for the postgraduate. Pressure can be generated by a person, bag or ventilator. Flow is created and it goes through the airways, and ultimately this causes the change in volume, and this is the volume. Now, how does the mechanical ventilator work? There is inspiration and there is expiration, no doubt about it, isn't it? Now there has to be some way where inspiration will be changed to expiration. The machine needs to understand, okay, that my inspiration is completed. Now I need to go to expiration, and my expiration is completed, and I need to go to inspiration. So how does this happen? So there are three important parameters for a basic ventilator understanding, which all of postgraduates should definitely know. So one is, whenever there is termination or what we call as cycling, that is something is a triggers the change from inspiration to expiration. We'll look all this in quite detail. Then there is something called as trigger, which will change from expiration to inspiration. There'll be some trigger which will tell the machine that, okay, my patient now needs to breathe, and let me give an inspiration breath. And then there are something like, how do you decide what is inspiration? So there has to be a target, which will be a target of inspiration, because it's an active process. So remember these three terms, that is trigger, target, and termination or cycling. So now what is trigger? How is inspiration set on a ventilator? It's very simple. Either it can be a time trigger or it can be a patient trigger. Now, when we say about time trigger, in our day-to-day mechanical ventilation in operation theater, you paralyze a patient, isn't it? After a paralysis, you set a respiratory rate of say 15 seconds. Say 15 respiratory rate has been set for the patient. So that means, and at a ratio of 1 is to 2. So what will happen is, whenever you have an inspiration of 1.5 seconds and expiration of 2.5 seconds in this respiratory cycle. So what will happen is, the machine will send that after 1.5 seconds, my inspiration needs to start. I mean, my expiration is finished, and now I need to start inspiration. So this is a time trigger. Okay, this is like a ventilator set. Then the second thing is patient effort. This is especially very useful for your ICU patient, because in ICU, paralysis is never the answer, and paralysis should be used only and only as a last resort in refractory hypoxemia. Don't use paralysis as a routine thing in ICU patients in mechanical ventilation. Now, how does a patient trigger a ventilator in a ICU? So there are two types of trigger: pressure and flow trigger. So we'll just see what they are. Now imagine this is the ventilator circuit and this is a patient's flow. There is something what we call as the base flow, which is always going in this circuit. So for example, from 10 liters from one side, the patient's flow will be there. And if patient is not taking any breath, the expiratory side, it will again have a 10 liter flow. So what is happening is, at the inspiration and expiration, there is a calculation. At the inspiration side, there is a calculation that I have sent 10 liters of flow to the patient circuit, and at the expiration there will be say, okay, 10-liter flow has come. That means patient is not taking any breath. Now imagine the patient starts taking some amount of breath. So what will happen is, for this 10-liter, maybe 1 or 2 liters will go down to the patient side, because he's trying to take a breath, isn't it? He's trying to take a breath, and maybe 8 liters will go back to the expiratory valve. So the valve will sense that there is a 2-liter trigger which has happened, and now based on how much of flow trigger you kept, it will give an inspiration. So flow trigger is one of the most physiological ways of giving a trigger. Flow pressure trigger, it is something again like a pressure. Whenever you take a time to take a breath, there will be change in the pressure, and this pressure will be changed again by these valves. But the commonly used trigger in a mechanical ventilation is a flow trigger, and one keeps a flow of around 1 to 2 liters around is one of the commonly used flow. If you keep too high a flow, patient will require more and more amount of work to be done, and he is not in that capacity. So you are causing more amount of, like, patient is starving for the flow. And if you keep it very slow, say 0.5 or 1 liter, probably even like if the patient is moving here and there will be a too sensitive processor, and there will be a lot of dyssynchrony. So you need to set your flow trigger very nicely. A 2 liter of flow trigger is something which is commonly accepted. Now, the second thing we talked about was target. So target is flow of air into the lungs. So how do you decide on that part? So basically, predetermined flow rate or predetermined pressure limits. So volume control ventilation, you will have a clear cut predetermined volume, and for pressure limit, you will have a predetermined pressure limit. And the third step was termination of inspiration. That is, my target has achieved. So how do you decide? So volume delivered, that is the set tidal volume when has been delivered. Either a flow has reached, like whatever you have said, I should go to a 65-70 liters of flow has reached, or as in your paralytic patient, time of inspiration has completed, isn't it? So these last few slides I will be taking, we'll talk about. So we have seen the pressure, flow, and the volume, what they mean. Then we have seen the inspiration and expiration, and the three T's which are important, that is the target, trigger, and of course the cycling, that is the termination part. Now based on this thing we can talk about various modes of ventilator. So we need to understand that there can be two things. One is ventilator support. When we talk about, there can be a spontaneous or there can be a controlled way. So in spontaneous, what happened? The rate is also determined by the patient, and the power is also determined by patient, like something like what we are doing, isn't it? And we are maybe adding us only a small power to the patient. In the controlled ventilation, what is commonly seen in the operation theater, the rate is also determined by the machine, and the power is also determined by the machine. Machine means what we have done it, isn't it? Now there is something called as assisted mode in between. So what happens in assisted mode is rate is determined by the patient. Says I keep a rate of 10, and if the patient is taking 20 breaths, so machine will give support to 20 breaths, but the power is something which is given by the machine mode. So spontaneous mode, assisted mode, and control mode. And then there is something called as the assist control mode. Very important to note the difference is there is a minimum rate which has been kept by the machine and additional rate which is taken by the patient. For example, if I talk about pressure support mode, so what will happen in pressure support is there is no minimum rate. So whatever rate patient is taking, all these breaths are supported by the machine. And when we talk about the assist control mode, for example, volume assist control mode, so I'll keep a respiratory rate of say 10, and if the patient is breathing additional 5, so the additional 5 will be supported by the machine. So this is a pretty standard way. So just remember these four things: spontaneous, assisted, assist control, and control. They are almost like a spectrum. Okay. So volume control, these are the 5 important breaths. We'll just look into this and we'll stop after this. So when we talk about volume control, volume assist, pressure control, pressure assist, and pressure support. So volume control. So what will happen in volume control is there will be a time ventilator. The target will be set flow and tidal volume, and the termination will be once we have delivered a guaranteed tidal volume to the patient. Now what is fixed here is volume. I want to give 500 ml, that is fixed. So and what will be changing? Your pressure. As your lung compliance, if you have a good lung compliance, your pressure will be low. If you have a bad lung compliance, you will have a higher pressure. What happens with volume assist control is, you remember the trigger in volume control, it was like a paralysis patient, isn't it? What we did in operation theater. In volume assist control, the trigger can be either the patient or in some cases the machine minimum set rate. Rest remains same. That is, the fixed part is volume and the variable part is pressure. Now in pressure control, there will be other thing. Your fixed thing will be pressure. Like I want to give 20 centimeters of pressure. In what will change is volume and flow. If you have a very good lung, you might be generating 600 ml, 700 ml tidal volume. But if your lungs are very bad ARDS, even with 20 centimeter, you might be generating only 250. Again, in pressure control, that is in paralysis patient, the trigger is time. In assist control, the trigger is patient, that the patient is giving breath, and for every breath, the pressure is being delivered to the patient. And last mode important to remember is pressure support. Here, the trigger is always patient. There is no fixed respiratory rate. The fixed thing is pressure. That is, you decide that I want to give 10 pressure support, and the change will be volume and flow. What is important to note is there is no fixed respiratory rate for these patients. Okay. Now we talk about tidal volume. We all know that tidal volume is not by your original body weight, but by the ideal body weight. And there is a divine formula. Generally, you need to remember for Indian females, tidal volume of 265 to 420, and for males, 280 to 450 something we call as the low tidal volume. That is 4 to 8 ml tidal volume is something we require. Gone are the days when we set a respiratory rate or a tidal volume of 500 ml. Next is we talk about FiO2, PEEP, and respiratory rate. So FiO2 becomes very important. Okay. So let's talk about how do you set an initial ventilator. Initial, you decide whether my patient needs mechanical ventilation, then decide about invasive or non-invasive, then decide whether this will need a partial or full support. Then you, as we discussed, spontaneous, AC, IMV or control mode. Then you decide which is better, volume or pressure. Remember, very important thing, there is no difference. Both the modes, volume or pressure, whatever you are familiar with, works almost same. There is no change in outcome in the terms of mortality for this patient. And then you talk about initial settings in the term of FiO2, respiratory rate, PEEP, and target. Remember, Lung protective ventilation is useful even now in day-to-day settings, even in operation theater when you have a normal patient coming for normal lung. So no longer only for ARDS, but for all things. Always start with a higher FiO2 and bring down very rapidly to a lowest FiO2 where your saturations are around 95. Respiratory rate, don't go in a fixed mode. Okay, for all mechanical ventilated patient, my respiratory rate will be 15. If you have a patient who is very badly septic, he is hyperventilating, the moment you decrease the respiratory rate, your patient will have metabolic acidosis. He was trying to compensate that by a higher minute volume. You decrease the respiratory rate. Now he is additionally going into a respiratory acidosis. So never set a respiratory rate just blindly 15 for all patients. It depends upon the patient's need. You have a COPD patient, you will have to do a low respiratory rate. PEEP, always start with a lower PEEP, say 5 or so, and depending upon your FiO2, you can go and target and trigger. We have already discussed. These are just some of the things where they say lung protective ventilation now is useful for all the patients and should be employed even in operation theaters. So this is something which we have already discussed. So just we need to keep it simple and be understanding about the basic thing. We'll not do the scalars today, and I'll stop here. We are discussing this and we sort of for time positive we were doing it for. Now PEEP is very important for all the mechanical ventilation setting. If you must have seen in traditional thing, what we used to do in our mechanical ventilated patient in our under anesthesia was we used to keep PEEP of 0, and this was nothing but basically like probably an old age teaching which was going over a period of time. But what has now been seen is that repeated mechanical ventilation trauma, it creates 4 type of traumas to your patient. So it's not like that a positive pressure ventilation is a good thing for patient, isn't it? There's a athlete trauma, there's a barotrauma, there's a volute trauma, and of course there is a chemical trauma which happens because of a positive pressure ventilation. Out of this thing, when your lung alveoli they repeatedly collapse and open, there are 2 possible things which happen. This is called as athlete trauma, and because of this repeated closing and opening, there is something called as a chemical trauma. There are releasing of lot of cytokines. So what now is recommended is that you should always keep a minimum 4 or 5 centimeters of PEEP for all the patients, even in normal healthy lungs. And why the reason is that the main reason is to prevent the athlete trauma for this patient, and especially what happens under general anesthesia in controlled mechanical ventilation, we give paralysis to the patient. The diaphragm is the main thing which is keeping our lungs very nicely open. We all understand it's the biggest muscle supporting the ventilation. The moment you do paralysis to the patient, your basal zone, the dependent zones of lung, have a tendency to go into sort of atelectasis. The closing volume concept, that is the minimum volume, you will start setting in, and your alveoli in the basal region will start to go into collapse. Now, one of the easiest ways to keep this thing open is to keep a minimum PEEP of around 5 centimeters of water. The theoretical concerns with PEEP is that PEEP will cause a lot of hypotension, it will increase the intrathoracic pressure, and you should not be using it in a septic shock patient and all whatnot. Higher PEEP is something which will cause a problem to this thing. A minimum 4 or 5 centimeters of PEEP will not cause a problem of in decreasing the venous return or your septic shock patients. It will increase the oxygenation, it will prevent your atelectasis, it will create your lungs opening, and you will have less amount of post-operative pulmonary complications. Like we talk about MACE, that is major adverse cardiac events. Nowadays we are talking about the PPCs, that is the post-operative pulmonary complications, and PEEP becomes very important part of this. Another important content in PEEP is neurosurgeons, they don't like PEEP. There's a traditional setting that probably PEEP hampers the venous return and it increases the tendency of ICP. But be very clear that it has been found in many research that almost a PEEP of around 10 to 12 centimeter, if you are not on a higher PEEP, it probably doesn't hamper your venous return, and a physiological PEEP somewhere around 5 to 6 centimeters of water is useful even in neurosurgical cases. There are something called as the suture's walls throughout your internal jugular vein and everything, which prevents sort of transmission of this back pressure into your venous draining system. So be it neurosurgery, just to make a short gist, be it neurosurgery, be it your septic shock patients, or be it other places, or be it your day-to-day routine patients, ASA1 patient where you are doing a simple mechanical ventilation, use PEEP as 4 to 5 centimeters of water, and it will be helping you to prevent this athlete trauma and post-operative pulmonary complications.